Good afternoon, everybody, and welcome back to Grand Rounds. Today, I have the pleasure of introducing Dr. Laura Raffals. Dr. Raffals is a clinician and an educator at the Mayo Clinic. She's a professor of medicine at the Mayo College of Medicine. She's also a consultant in the Division of Gastroenterology and Hepatology. She's vice chair in the Division of Gastroenterology and Hepatology, and she's associate chair for faculty development in the GI and internal medicine departments at the Mayo Clinic. So she wears multiple hats. In addition, she is regularly recognized for her excellence as an educator. She's been awarded the Teacher of the Year award there by residents and fellows on multiple occasions, and we're really very much appreciative of the fact that she found time to join us today to provide us with a review of inflammatory bowel disease for the Generalist. And please join me in welcoming Dr. Laura Raffals. Thank you.
Thank you. Excuse me. Thank you. And thank you so much for the invitation to be here today. I hope to spend the next 45 minutes or so really just covering what I feel like are the key clinical pearls for managing patients with inflammatory bowel disease. And certainly there'll be time at the end to field any questions you have or any comments you may have in terms of your own experience managing patients with IBD. So you just my slides to advance here. So my objectives over the course of this hour are to talk about the importance of early intervention treatment of patients who are diagnosed with IBD. We'll talk about symptoms that can sometimes mimic IBD and the importance of recognizing those mimickers. We'll talk about the role of opioid medications in the IBD patient, the risk of DVTs and pulmonary embolism in hospitalized IBD patients. And then we'll talk about some very basic preventive measures that all should be considered for all of our IBD patients. I thought I would open it up with a case just to help us put into context some of the issues we see with patients who are newly diagnosed with IBD. So this is Victoria. She's a 28-year-old woman who was recently diagnosed with ileal Crohn's disease. And she presented with a partial small bowel obstruction. And that's when her diagnosis was made. She otherwise is healthy, but it is important to note she does have a smoking history. During her hospitalization, she was given a course of steroids and did feel some improvement. And upon discharge, when you meet her, she's taking 20 milligrams a day of prednisone and feeling pretty well. So the question is, what is the most appropriate treatment to start on Victoria to manage her Crohn's disease? So we could think about a longer-term course of budesonide, mesalamine, infliximab, azathioprine, or ustekinumab. So I'll give you all a second to think about this, and then I'll tell you what I believe the correct answer is, and then we'll discuss why. So think about if you were to see this patient, what you might start. And what I will tell you is the correct answer here is C, infliximab. So let's talk about that and why that would be. So the first thing I'm going to say is our treatment goals in managing patients with inflammatory bowel disease have rapidly evolved over the course of the past decade or so. So I can tell you when I was training, which I'd love to say was just a few years ago, but probably more like 20 years ago, we were pretty happy if we can make patients feel better. If their symptoms were under control, we'd say, this is great, we've induced clinical remission, that's exactly what we want to achieve. The reality is that's not good enough now. Not only do we want our patients feeling well, but we want them well off of steroids. We want to improve their long-term outcomes and prevent complications from their disease. And in order to do that, we really need to strive for mucosal healing. We believe if we can heal the mucosa and achieve that degree of success with our therapies, we can actually change the natural course of the disease. So my number one clinical pearl is early intervention strategies are absolutely key to managing patients with IBD successfully. So I'm going to give you an example or explain why that's the case over the course of the next few slides. What I will tell you is over the past decade, we've had so many new medications come to the market that allow us to take better care of our patients and really improve clinical outcomes. This field is evolving so rapidly. What I can tell you is just since October of 2023, we've had 4 new drugs get FDA approval. So the drugs are getting approved quickly. We have more drugs in the pipeline. But what has occurred because of all the great drugs that have been approved is we're really doing a much better job managing our patients with inflammatory bowel disease. but it's critical to intervene early. So I'll tell you, as always in IBD, we follow our rheumatologists, who are much smarter than us as gastroenterologists and always seem to teach us the hard lessons that they have learned. But one important lesson that we have obtained from our rheumatology colleagues is that there is a critical window of opportunity to intervene in patients to change the course of disease. So an RA, as an example, which we think of as being the first cousin to Crohn's disease, if you can intervene in a patient diagnosed with RA soon after they develop symptoms, what you can see is you can actually prevent some of the late complications with irreversible loss of function. So you can change that course of disease if you intervene early with RA. We think we see something very similar in inflammatory bowel disease, and specifically Crohn's disease. So we believe, similar to RA, if we can identify patients during this ideal window of opportunity soon after they have onset of disease, we can prevent that inflammatory burden, which results in subsequent complications from disease, such as fistulas, abscesses, strictures, et cetera, that then require the need for surgery and sort of other just long-term sequelae from the disease. So we know the natural history, again, is the burden of inflammation increases, complications increase, then the risk for surgery goes up. And of course, the patient's symptoms, which is represented in this green line, go up and down over time. But if we can intervene early, the thought is we can actually prevent that inflammatory burden and subsequent complications and really improve the overall outcomes for our patients. We've had some data to show that this theory is actually likely true. And we can really glean from clinical trials that in the clinical trials where patients had a lesser duration of disease at the time of enrollment, the percentage of patients achieving remission are significantly higher. So these are several of the larger Crohn's disease trials that you can see here. And in the trials where the duration of disease was shortest, under 3 years, you can see remission rates as high as 60, 70% compared to what we typically see in many of our clinical trials of around 30% or lower. So again, this idea of if we can intervene in a patient's disease early, we have a better shot at achieving remission, which is our ultimate goal. But having said that, it's important to individualize treatment based on a patient's risk for developing complications from disease. So even though we have some great medications, we don't necessarily want to overshoot and use medications that have potential side effects or significant costs in a patient whose risk of developing complications is low. So how do we individualize treatment appropriately for our patients? So let's talk about how we can approach that. And I would argue we need to think about disease activity and disease severity, which are different concepts, but really are important to piece together as you look at the whole picture of your patient's disease. So disease activity is really an assessment of how your patient is today. When you're seeing a patient in clinic, how are they today as they sit there in your clinic? What is their inflammatory burden today? What symptoms are they experiencing? What does their endoscopy look like? Their labs look like? Their radiology exams look like? That activity today is often what the patient is concerned about as they present in your office. But we also have to think about their severity. So that's their entire disease course. What are the historical factors? Have they had surgery? Have they been on steroids for a long period of time? What is the overall burden of their disease? And as we think about those factors, what are the long-term risk of future complications from their disease? So disease severity, again, is really looking at the overall burden of their disease, whereas disease activity is how are they today? Both of these factors are really important to take into consideration as you think about a treatment strategy for your patient. So we have some studies. A few of these studies are old studies, but we refer to them often that help us predict who is going to have a more severe disease course compared to maybe who is going to have a very mild disease course. You can probably think in your clinic, there are the patients who have Crohn's disease who maybe had surgery back in 1980, a small bowel resection. They've never been on medication since that surgery in 1980. They're still doing great. Occasionally, maybe they have a few bowel symptoms here and there, but overall doing well. That's very different from a patient who's maybe 15 at the time of their diagnosis, who has perianal disease, who's developed intra-abdominal abscesses as well. So those two phenotypes are very different, and I would argue that we need to approach those two patients very differently as well. So some of the clinical risk factors that we believe are associated with a more disabling disease course, which we define as folks who are more likely to need steroids, more likely to need surgery, are folks who are diagnosed at a younger age, active smokers. So we know active smokers with Crohn's disease do worse than non-smokers. Patients who have perianal disease, so perianal abscesses or perianal fistulas at the time of diagnosis, or patients who require steroids for the initial presentation of their disease. So if you have a patient who has two or more of these clinical risk factors, they are extremely likely to have a more disabling disease course. There was a subsequent study where they did a systematic review looking at all the publications up to 2014, trying to identify those factors, again, clinical factors that would predict a poor outcome or more severe disease course. And again, younger age of diagnosis, weight loss. We know small bowel disease tends to portend worse outcomes than patients who have chronic disease. Severe endoscopic disease at the time of diagnosis. Again, seeing that perianal disease, again, come back as a risk factor for worse disease. And then complications at the time of diagnosis, such as strictures or penetrating complications, which could be an intra-abdominal fistula or intra-abdominal abscess or bowel perforation. So none of those should be terribly surprising as risk factors for worse disease. And a few other things to consider, again, are that initial requirement of steroids, smoking, and then some blood work, such as C-reactive protein or ASCA serology as being positive or certain genetic mutations. So again, here are some clinical factors consistent with the older study I showed you just a moment ago, suggesting what risk factors at the time of diagnosis will suggest somebody may be at risk for disease complications. We also don't have quite as much data for ulcerative colitis, but there are a few clinical risk factors that we believe do suggest worse prognosis for patients with ulcerative colitis. And that would be, again, sort of an older age of diagnosis, although there is some data for younger age as well. Extensive disease, so patients who have inflammation beyond the splenic flexure, patients who have primary sclerosing cholangitis, deep ulcerations, need for steroids soon after their diagnosis, and early hospitalization as well. So let's talk about how do you choose IBD therapy. What I want to argue here today is you need to intervene early and get patients on appropriate therapy soon after diagnosis. But also you want to be somewhat discriminatory and recognize that not every single patient needs an advanced therapy or what we call top-down therapy at the time of their diagnosis. However, what I find is it's very rare for people to overshoot on their therapy regimens. In fact, what we tend to see are people undershoot and probably going a little too timid in terms of the treatment regimens people start patients on. But you do want to recognize that patient who really is at low risk for having disease complications. I'll use ulcerative colitis as an example. Somebody with mild inflammation involving the distal 20 centimeters of their colon, that patient does not need to start on infliximab right after their diagnosis, but could probably benefit from a trial of mesalamine as an example. So again, just really trying to identify who's at a high risk versus low risk of disease complications. And based on that, personalizing your treatment plan accordingly. So young patient, perianal disease, small bowel disease, we're going to be aggressive, get that patient on the right biologic therapy right out of the gate. Whereas somebody with really mild disease, we'll use, again, the example I just gave of mild left-sided ulcerative colitis, probably don't need a biologic therapy, could probably start that patient on mesalamine. And then you want to communicate the plan really clearly to the patient and everybody involved in the patient's care. So what I also find is often after a treatment plan is started, what's not clear to the patient is what that follow-up plan should look like. So anytime a therapy is started on a patient, you want to be sure that you have a check-in planned at least 4 to 6 months after starting a therapy to ensure that the patient is responding to the treatment plan so you can pivot and make adjustments if you need to, if things aren't going as you might hope. And that brings us into the other key treatment strategies that are required to improve overall clinical outcomes. That is ensuring that you are treating to target, meaning you are confirming that your treatment regimen is working, and then tightly control monitoring that treatment strategy. So making adjustments as you need to ensure patients are getting the full benefit from their treatment plans. So let's talk about treatment goals in IBD. Again, these have evolved over time too. I love this slide because I think it really shows how we've evolved as a field and what our expectations are for our patients. I mentioned on one of my first slides that back when I was training, we were really excited if our patients achieved a clinical response and remission, that they felt well, we felt their symptoms are under control. That's no longer acceptable. We want our patients to be in a deeper remission if possible. And what we mean by that is we want to see not only symptom control, but we want to see healing on endoscopy, ideally on histology too, although recognizing that's not always possible and we don't know for certain, if it's a bad thing if we have endoscopic healing, but the mucosa is not completely healed. And if we do that, what we do know is that we see sort of the improvement in clinical outcomes, preventing hospitalizations, avoiding surgeries and other complications. And we know that if we achieve endoscopic and mucosal healing, the likelihood that that person will remain in long-term remission goes up significantly. So we achieve that endoscopic healing, we know patients are less likely to have flares down the road and will be more likely to stay in long-term remission. Now, I've said all of this, I've said how important it is that we achieve endoscopic remission, but what I'm also going to say is balance that with don't give up too soon on a treatment. This is another mistake I often see in patients who are being managed as we have done such a good job as a field of saying we expect more than just patients feeling better. We want to document that they have an endoscopic healing. We want them to be perfect. But then the problem is sometimes we don't give treatments enough time to do their job. And we abandon a treatment and move on to something else, and then we burn through treatments too quickly. So you need to optimize treatments before moving on to a new treatment, if, in most cases. So if you have a patient who's put on a therapy, and they're not responding, you want to be sure you understand what's the reason for non-response in this patient, or do they initially respond to a treatment and they've lost response? And if that's the case, you want to be sure you understand why they've lost response or why they haven't responded. So a few things I'm going to say is we know that if we can determine a patient's not responding because they've had partial response, but they're not as far as they need to be, it may be that their dose is not optimized and there's an opportunity to increase the dose to get more bang for our buck from that treatment. Some cases, we can see patients responded well to a treatment, but lost response. So they were good, then all of a sudden they're not good. Then you need to think about why is that? Is there an infection that is sort of making it impossible, that is causing this patient's symptoms? If they're on a biologic, do they develop antibodies to this drug? Did something happen in terms of their pharmacokinetics? Did they gain weight? And so there's a difference in how they're clearing the drug or drug levels, et cetera. So you need to try to do a little bit of investigation to understand why somebody's either not responding or has lost response to a treatment they are on. What I do want to say is sometimes we let perfect be the enemy of good when it comes to managing our patients with IBD. So just to level set again, I feel like I'm giving mixed messages, but I think this is important. We want to aim for mucosal healing. We want our patients to have healing of the bowel. However, The reality is many of the patients in clinical trials do not achieve mucosal healing. Now, that's typically a very sick population of patients who've had disease for a long time. But we have to recognize mucosal healing is the goal, but it may not happen for everyone. And so sometimes we need to, if we see significant improvement in somebody's disease, but it's not perfect, it may be, let's say this patient has been on 4 advanced therapies and they're not perfect, but they only have mild inflammation at this point. They're doing quite well. Sometimes you want to hang tight on that treatment regimen because it's the most success you've had, as opposed to burning through another drug. So there is some art to this of knowing when you accept the treatment success you've had versus when you say, this treatment's not working, we need to move to something else. One point that's really critical is you do want to be sure that you give any treatment you try for a patient enough time to be effective. And that differs from drug to drug. So infliximab, as an example, works pretty quickly. We usually know if it's going to work in 4 to 8 weeks. On the contrary, vedolizumab, another biologic therapy, is very slow acting. And in fact, the reason why it's slow acting is it doesn't do a whole lot for the inflammatory cells that are in the GI tract. It stops more inflammatory cells from getting into the GI tract. So there's probably about a 3 to 6 month wait to see the full benefit of vedolizumab. So you want to be sure you allow vedolizumab enough time to work before you give up on that drug. So you need to, as a good rule of thumb, I always give 3 to 6 months for a treatment to reach its full efficacy before I determine it's not going to work. Pearl number 3 is don't mistake symptoms for inflammation. So our patients can often have symptoms, but symptoms alone do not always equate to inflammation. So there are a lot of things that can mimic inflammatory bowel disease or active inflammatory bowel disease. So infections, very common. The one that's most common, of course, is C. diff, but we see other infections in our patients with IBD as well. Patients who are on advanced therapies for IBD are also at risk for CMV. So you need to think about CMV in those patients, and certainly C. diff. If you have a patient who is doing well, but then they develop diarrhea, they're not responding to treatment, you need to think about infections. Ischemia is not common, but can certainly occur and can mimic IBD. Another common one is bile salt malabsorption, particularly in any patient who's had ileal disease or a small bowel resection of the ileum. They are really at risk for bile salt malabsorption. And so honestly, just trying some cholestyramine or Cholestid to see if that helps these patients. It works quickly and dramatically in patients who have bile salt malabsorption. So thinking about that. And then our patients with IBD have many functional GI issues as well. If you think about it, the analogy I like to use is if you have a really bad burn on your skin, even after the skin is healed, it can be very sensitive there where that burn was. Your gut's the same way. If you've been really inflamed, the inflammation may heal, but those nerves still may be overfiring, and there may be some visceral hypersensitivity from the prior injury to the bowel. So these patients are at risk for functional GI issues. And then certainly anxiety can play a big role in symptoms as well. Some other complications from chronic long-term disease that can impact symptoms would be chronic stricturing, very common. If you have fibrostenotic disease, the stricture in the small bowel, there is no medication in the world that can reverse that, at least not yet. And so that's a complication that throwing more steroids or more medication at is not going to be helpful. And some of our patients, I see this probably the most in ulcerative colitis patients, can develop from chronic inflammation some dysmotility of the GI tract. So we know patients with ulcerative colitis who've had a lot of rectal inflammation, they start to lose the distensibility over time of the rectum, which can cause more urgency than you might expect, even in the absence of inflammation. And then another one of my favorite catches that I have in clinic is patients often will have pelvic floor dysfunction, possibly as a result of their IBD. So if you think about an ulcerative colitis patient who has struggled with diarrhea for years, they often have trained their anus to squeeze. That's a muscle like any other muscle. And then they lose the ability to consciously or subconsciously relax to have a bowel movement. So they sometimes can really struggle with evacuation disorders just because they've been so afraid of fecal incontinence for so long that those muscles quit coordinating appropriately. So I've already talked about infections. I just again will highlight that they're common in patients with IBD, and the most common of those would be C. diff. So anytime you have a patient who is doing well, and then they're suddenly not doing well, you want to be sure before you escalate their IBD treatment, you want to be sure there is objective evidence of inflammation before adding steroids or dose increasing or changing therapy plans. So if I have a patient who's flaring, if that flare is defined by diarrhea, I will always rule out stool infection. And I often like to do some objective assessment, whether it's a fecal calprotectin, a Flexig, some imaging study, to be sure I can confirm inflammation before I change the therapy plan for that patient. We're going to move on to a couple of different topics now, but the next pearl number 4, is opioids are not a safe pain medicine strategy in IBD. This is so important. This is challenging because our patients often want opioids. They want a quick fix to manage their pain when they're hospitalized. But really, this is just not a safe pain management strategy for our IBD patients. I'll start by talking about the scope of the problem. So around 10% of our IBD patients are on chronic narcotics in the outpatient setting. So fairly common. And we know that the majority of patients who are hospitalized will receive narcotics during their hospitalization. So this is a problem because we know that narcotics are associated with increased mortality and increased complications, particularly in the hospital setting. In fact, on our inpatient service, we rarely will prescribe narcotics for an admitted IBD patient. This can be challenging, and I think the key here is understanding what causes pain in the IBD patient. Pain is often driven by inflammation. And so sharing with the patient that our strategy to manage your pain is to get the inflammation under control as quickly as possible, and using alternative strategies outside of opioids to manage that pain can be very helpful, but it does require the time of talking with your patient and explaining you're not trying to make them miserable, that you are really trying to keep them safe while managing their pain in a safer manner. So I think that conversation with patients is absolutely critical. Now, a caveat is if I have somebody with horrendous perianal disease, as an example, that may be a situation where I will use narcotics, but it's a pretty rare exception that I will prescribe narcotics in the hospital setting. So again, the primary method of pain control in IBD is disease management. And then you can use acetaminophen safely. I use acetaminophen. I use a lot of hot packs. We will use canine therapy. We will use acupuncture. You should avoid NSAIDs if possible, although having said that, our surgeons will often use NSAIDs in the post-operative setting as opposed to opioids. And I think in a very short course, NSAIDs can be used, but as you are probably very much aware, NSAIDs can increase the risk for flaring disease. So you need to be careful about that. And then for long-term support, more in the outpatient setting probably than the inpatient setting, there may be a role for antidepressants and psychological support. So I throw that out there as alternative strategies as well. But I really think this is an important take-home point and hopefully one that you'll think about next time you're caring for a patient who's in pain, understandably, but trying to think and challenge yourselves of how can I manage this pain without using an opioid. We're going to move on to the next topic, which is DVTs and PEs. And so again, I'm going to present another patient. This is Bob. Bob is 65 and has pan-ulcerative colitis. And he's hospitalized for a flare of his ulcerative colitis. And he is having 20 frankly bloody bowel movements. So he's just passing blood, 20 bowel movements a day. Hemoglobin is low at 7.8, and platelets are elevated. The question is, what is the most appropriate DVT prophylaxis for this gentleman? So one would be an IV low-intensity heparin drip, possibly baby aspirin, apixaban, low molecular weight heparin, or maybe you should avoid all medications and use SCD boots and encourage ambulation. So I want you to think about that for a moment. Think about what you might do in the hospital setting for this patient. And then I will tell you what my recommendation is. So I would recommend D, low molecular weight heparin. I find people are often very nervous to give even prophylactic anticoagulation in a patient who is having frankly bloody bowel movements and is anemic. However, the risk of bleeding out from prophylactic anticoagulation is exceedingly low, but the risk of DVT is quite high in these patients. So there are really no exceptions in terms of saying a patient should not receive DVT prophylaxis. So this is really critical for all of your IBD hospitalized patients. We know that the annual incidence of thromboembolic events in IBD is quite high. And compared to the general population, there is a threefold risk of DVT or PE in the IBD patient. And that risk is increased substantially during active flares, more so with colonic flares of disease than small bowel disease. I don't know why, but colonic disease, particularly ulcerative colitis, seems to have a higher risk of DVT and PE. And we do know as well, PE and DVT are the most common thrombotic complications in IBD. So despite that, there was a study that was published a few years ago that showed that despite the high risk of venothrombotic events in the hospitalized IBD patient, only about a third of hospitalized patients were receiving prophylaxis. So the take-home point here is it is okay to use prophylactic anticoagulation. These patients, the bleeding that you're seeing is usually rectal bleeding. Even though it appears to be a lot of blood and patients are anemic, they're not exsanguinating. And it's important to get these patients on prophylactic anticoagulation. In fact, these patients are even at highest risk the first 2 months after they are discharged from the hospital. So there's even been some discussion at GI meetings, should we be giving prophylaxis even after discharge? We don't do that. That's not recommended at this point in time. But I do think it's important to educate patients that they need to stay active. They need to keep walking to help reduce that risk of DVT or PE, because particularly with colonic flares of disease, that risk does increase. Then I'll finish with a few more preventive care needs of IBD patients, and then we can open it up for discussion for any questions you may have. But I want to highlight my last clinical pearl here, that IBD patients have significant preventive care needs that we don't want to lose track of. And what I often find is IBD, and it's not that I find, this has actually been reported, IBD patients do not receive preventive services at the same rate as general medical patients. And I think this happens for a few reasons. This has been discussed at meetings quite a bit, is I think IBD patients often will look to, if they're seeing a gastroenterologist, sometimes they will look to that GI doctor as their primary care physician to some degree because they're seeing that GI provider regularly. However, the GI provider assumes that they're receiving preventive care from their primary care provider. And so there's almost this hot potato game going on that nobody's actually owning the preventive care needs of this patient, and so it's just not happening. And so this is why I think it's so important for there to be close communication and collaboration between all the care providers taking care of a patient, just so that we know who is taking ownership and ensuring that this patient is receiving all the preventive care needs that they have. And so for IBD patients in general, some of the unique needs they have are vaccinations, which I'll talk about in a minute, They often have higher needs for screening for osteoporosis and cervical cancer, particularly patients who have been on azathioprine or biologics. They need to be screened regularly for HPV and cervical cancer. They can often be at increased risk for skin cancer. So we know the risk of melanoma is increased in patients with IBD, and we think maybe some of the biologics, anti-TNF therapies can increase that risk of melanoma. But certainly azathioprine or 6-mercaptopurine significantly increase the risk of squamous cell cancers and basal cell cancers. So that skin cancer screening is really critical for those patients. And then we also know our patients, due to the impact of their disease on their life, so that risk of depression and anxiety can be really high in this patient population. And then I've sort of touched on, but probably not emphasized enough, patients with IBD really need counseling on smoking cessation just because of the impact smoking can have on long-term outcomes, not just from the obvious ones from tobacco use, but particularly in terms of IBD outcomes as well, and specifically in patients with Crohn's disease. So this is a resource I'm just going to give a shout out. Marla Dubinsky and David Rubin, who are two outstanding gastroenterologists, have a company they call Cornerstones, but they have put together this IBD checklist for monitoring and prevention, which is just an outstanding, regularly updated checklist of the screening needs of patients with IBD. You can download for free off the internet. If you literally just type in Cornerstones IBD prevention, this will come up. But it really is a great resource for the primary care physician or the gastroenterologist who wants to keep track of all the different preventative care needs IBD patients have. I already spoke about the importance of coordinating who is going to oversee preventative care in these patients. And again, just the importance of the various aspects that I talked about on the last slide. Let's talk about vaccination. So this is interesting. We've made little headway over the course of time of improving vaccination rates in patients with IBD. This is a few years old, about 5 years old, but back in 2006, they looked at the rates of vaccination in IBD patients. And if you look at pneumococcal and influenza as examples, we didn't do a great job of vaccinating our patients back in 2006. Very few patients were actually up to date on those vaccines. And the reasons for non-immunization were lack of awareness or concerns for side effects. Those are the two most common reasons. Then you fast forward 10 years later in 2016, and we did make a lot of headway for pneumococcal, although I'd still say that our rates were lower than what you would hope for, but really didn't make much headway at all for influenza. So still opportunity for us to do better. But this is just a nice, I would say, table. This at Frank Ferre, who's at Mayo Clinic in Florida, has done a lot of the work in really highlighting the preventive care needs of our patients. And actually his position paper in the Red Journal is the one that I reference a lot in terms of preventative care needs. But he has outlined the vaccinations our patients with IBD should receive. And the key ones that I'll point out, we do recommend that our patients are up to date on hepatitis B. HPV, again, we do recommend the HPV vaccine now in all of our patients, and that's probably regardless of IBD. We recommend influenza for our patients, meningitis for high-risk adults. So really that one we focus on our college students and folks that we feel that are high risk. And then I'll talk a little bit about streptococcus pneumonia because this has changed. So pneumococcal vaccine has evolved over the last few years and has become quite complicated. I used to have it, memorized of exactly what to do with the PCV13 and PPSV23. I no longer even try to memorize this. I have this printed out. It's in my office. But this is just, again, you can take note of the reference here, and I assume you all have copies of these slides. But this is just a nice table in this recent paper that shows you the updated guidelines for pneumococcal vaccine. And again, it varies depending on what you've had in the past versus if you're completely naive to any pneumococcal vaccination. If you're completely naive, it's actually pretty easy. You just get the one dose of PCV20 or one dose of PCV15 followed by PPSV23 a year later. But again, it's gotten a little bit more complicated, but I find this table to be pretty helpful. Let's talk about bones. This is another area of preventive care where we tend to fall short. We know that osteoporosis is quite common in the IBD population, with up to 70% prevalence of osteopenia. And we know that the risk of bone fracture is elevated in IBD patients as well. We actually, in the CT interrographies we do at Mayo, we're able to look at bone strength now as well, and rather than doing a DEXA scan, which can also be another measure of the risk of bone fracture. So according to the American College of Gastroenterology, all IBD patients with one or more of the following risk factors should have a DEXA scan. And those are your postmenopausal women or men who are over the age of 50, certainly if they've had a history of vertebral fractures or chronic corticosteroid use. So for me, if somebody's been on steroids more than 3 months, they get a DEXA scan or a bone strength scan on their CT interrography. If that initial screen is normal, then the recommendation is repeat DEXAs every 3 years or so. And then anybody who has had long-term corticosteroids or low T-score should really, in my opinion, be followed by endocrinology to be managed and be put on appropriate therapy to protect their bones. So the alarming stat that I'll share with you today is only 23% of IBD patients at risk for osteoporosis or low bone mineral density are actually screened. So we're not doing a good job screening our patients who are at risk for low bone mineral density. So just another request to think about bone health screening in our patients with IBD. So a few take-home points that I will highlight. One is that treatment goals in IBD do include deep remission. We want to heal the lining of the gut. If we can do that, we can hopefully prevent future complications from disease that often lead to disability. We want quality of life to be normal, and to get there, we have to intervene early with our treatment strategies. Or if somebody's had disease for a long time, we may not be able to get to completely normal, but we want to get to near normal. And what I will tell you, every time I meet a patient, particularly somebody with a new diagnosis, I tell them my expectation is that they should feel normal and live their life doing everything they would do if they did not have IBD. And that's our goal, is to get them to that point. Please do remember that not all symptoms are due to active inflammatory bowel disease. So you need to confirm inflammation before you make treatment changes and exclude other causes of active symptoms that, again, may not be due to active disease. And hopefully I made a strong case to avoid opioid medications in IBD patients because we know that they're associated with worse outcomes. And then finally, our IBD patients have really high preventive care needs. And that requires, all of this requires multidisciplinary care. And I think when we work as a team to care for our patients, they benefit greatly from that. And with that, I would be happy to take any questions. I will stop sharing. So I'm happy to answer questions in the chat, or feel free to just take yourself off of mute and ask any questions that you may have as well. Not hearing any questions. I don't know if anybody else can see any. Yes.
I'm not seeing any online.
Oh, here we go.
There's one.
It sounds like somebody commented, it doesn't look like we can unmute ourselves. So one question is, are steroids used at all in the acute management of IBD patients with flares? That's an excellent question. Yes, we still do use steroids. So we obviously want to avoid steroids when we can. However, many of our patients during an acute flare, we need those steroids to bridge us to whatever treatment strategy we see as the long-term treatment plan. So many of our therapies, we have to get prior authorization from insurance to either increase the dose of a drug or to start a new drug. Or some of our treatments take several weeks to actually start to kick in to help our patients. So we often need that bridge. The steroids provide that bridge to provide quick relief of symptoms, but it's not a long-term strategy. So anytime you start a steroid, you want to know, what is my exit plan off the steroids, and how am I going to use the steroids as a bridge and not a long-term solution? So I think that's the real key there, is short-term use of steroids sometimes is necessary. We do use often budesonide if we can, because that has less systemic side effects than prednisone. But budesonide doesn't work for everyone. And budesonide in the form of Entocort delivers the steroid mostly to the small bowel and the right colon. This is critical, not very good. So Entocort does not work well for ulcerative colitis. Different form of budesonide, Uceris, delivers this budesonide to the colon. That formulation works better for ulcerative colitis. So I see that often get confused for folks. So just remember, Entocort is small bowel, Uceris is colon, but budesonide is an option for corticosteroids as well. Great question. All right, I'm not seeing any other questions. I don't know.
Hey, Dr. Raffles, I'm not seeing anything here in the auditorium, and thanks for providing us that review. That was just perfect for our audience, so thank you very much.
Well, thank you for the opportunity, and I hope you all have an amazing day, and feel free to reach out if you ever have any questions. I'm always happy. I know Amber has my email, and I think it may have been on the last slide, but please feel free to reach out anytime.
Thank you.
Thank you.